So welcome everybody to today's Family Medicine Grand Rounds for July 13th. The activity code is listed here for those who are interested. Please just make sure that you do register before midnight tonight in order to claim your credit. We'll go to the next slide here.
Okay, and press continue on the meeting being recorded. Okay, do there. There we go.
There we go. So for those who are claiming credit, if you have not yet registered, the first time you use the system, you'll need to text your email address to the phone number listed there. And then from that point forward, anytime you attend any of the sessions, you'll just text attend and then the code for today, which is listed there for you, and you'll send that to that same number. But if you're having any issues, please feel free to reach out to me. Next slide. So as we go ahead and begin here, we want to thank everybody for joining us. If you could please just make sure that your microphone is muted as we get started. Also, if you could make sure that you are attentive and engaged in this session. And also, our speaker has asked if you have any questions, please feel free to put those in the chat box. We're going to be taking a look at those at the end of the presentation. So if you could please just put those in the chat box as we get started. And then I'll also be putting in the chat box as we get going, I'll put in the link for the feedback that we want to help provide to the presenter. So if you'll just make sure you help us with the feedback.
I lost the slide view. Sorry here.
That's
I'm
okay.
not sure. Oh, here we go. We got oops. Yes. Oops. All right. How do we what happened here? Oh, sorry. It was all good until just a second ago. And then I'll have to come back and do sharing. We'll figure this out. Share screen. And we've got this one. Okay, back there. Okay.
Okay. Sorry. No problem. So just to remind everybody, we are partnered with the South Central AHEC, and our department's mission statement is there for you to take a look at. Next slide. For those claiming CME, you may want to double check your CME transcript from time to time. You can do that by visiting the CME office website. I see that's kind of hard to see, but if you have any questions, please feel free to reach out to their office, or you can contact me as well. Next slide. Those who are members of the AAFP, please keep in mind that you can also claim credit through their system. You can reach out to them, or you can reach out to me if you have any questions. Next slide. We also like to mention during these presentations that it is our goal to address these nationally established physician core competencies that you see listed here. Next slide. And we do need to mention that Dr. Houston has no financial relationships with ineligible companies to disclose. Next slide. So today we have Dr. Houston joining us. I will let her give more of an introduction to herself, but her topic for today is assessment and treatment of outpatient alcohol use disorder.
Right. Can everybody hear me? Me some, just want to make sure we're good on that side. Is that
sounds good?
Thumbs up. Okay. Oops. Just go back. Okay. So my name is Dr. Houston. Thank you so much for joining me today. I'll be talking to you about assessment and treatment of outpatient alcohol use disorder. I do hope that you find this a practice-changing talk. I've got your attention for 45 minutes, so I hope that you learned something from this. A little bit about me. So I did a residency here at UTSCA, know Dr. Nato very well. I did 2.5 years focused in treating opiate use disorder in New York and had a really good mentor there. That time allowed me to do the practice pathway to certify in addiction medicine. And so right now, I work as in an outpatient mental health clinic, doing mostly mental health, but my addiction work is growing as I treat their mental health and addiction, and some dedicated addiction referrals too. Addition, in the pandemic, I picked up a small job doing alcohol-focused treatment called Join Monument. So this is in most states now. So I see a few patients a week, but focused for alcohol. So it's been really rewarding because a lot of people make change. They're coming on the platform because they really want to actually address their alcohol use. So, for anyone who's interested in specializing, know that there's a 1-year fellowship for addiction medicine, and that's open to all primary specialties. So family medicine, internal medicine, ER, OBGYN. You can have any primary board and do 1-year addiction medicine. So I would say that most people who are buprenorphine certified and doing addiction work have come from primary care fields. So 60% of Suboxone or buprenorphine providers are actually family medicine internal. So it's a chronic disease management, but go from there. Okay, so let me go. Here it is. I think I'm actually off. There we go. So my goals, objectives here. Understand how alcohol compares to diabetes. I remember being on the IPS unit, and there's lots of diabetes, but there's also lots of alcohol. And I think our focus tends, we forget about the alcohol issues that worsen diabetes, et cetera. I want you to be more familiar with alcohol use disorder diagnosis. I'm going to review some tools, some screening tools to talk about withdrawal, risky alcohol use to identify patients who might have alcohol use disorder or at risk for harmful outcomes for alcohol. And I specifically want to talk about management of outpatient withdrawal. This has been what's been practice changing for me. And then we'll review the treatments for alcohol use disorder too. So what's your experience been? Have you identified alcohol use disorder in your clinic? Have you had, what are the barriers that hold you back from treating alcohol patients? Have you ever written any FDA-approved medications for alcohol use disorder? What are your concerns about treating alcohol? I do want to take a few minutes here to just maybe get the lay of the experience of what people have been having. I don't know if we want to open the chat box here.
I've got the chat box open, so if anybody wants to answer any of those questions, feel free.
I'm gonna do the stop share for a quick second to see these chats. So anybody type in there, I'm looking for feedback. If you haven't assessed anybody for alcohol, never written naltrexone, just say never used it, written once. These just, I know we've got some experienced folks in the audience, but some residents too. Okay, nobody's chatting. Remember, your chat box is that if you go over the bottom there. Okay, so the nurse practitioner is saying that the mental health providers provide naltrexone. Okay, so one person's not written for it. Okay, okay. All right, so some, okay, and tell me, so Ms. Donnelly, is the mental health providers within the family medicine clinic? Is it a referral out? Just understanding how the practice is working. Dr. Ali. Or Ms. Donnelly, if you want to unmute yourself, you could give me that feedback. They're in the primary care center. Okay, cool. Go ahead, Ms. Donnelly. All right. Okay, so some people who haven't written for it, some folks in mental health writing for it. Okay. Okay, so the primary care is integrated with the mental health. Okay, great. So I'm going to come back to sharing my screen. Let me do that. I want to do share screen again, and we're going to go back to the PowerPoint. Okay. All right, and great, it came right back there. Okay. Okay, so this is a clinical case. Actually, let me just, sorry, let me go back here. And Okay, there we go. So this is a woman who I actually have seen on my telemedicine platform. So she's 40 years old. She had depression, childhood trauma, tobacco use, but otherwise she wasn't taking any medications. She came online because her goal was to stop her daytime drinking and improve her memory. At that point, she was drinking 10 plus drinks of bourbon and vodka per day. She'd had worsening issues over the last 3 to 4 years, worse in the last 4 months. She had a second fender bender and had been under influence at that point. Her spouse, she was arguing with her spouse over alcohol. She was missing events with her children. And she had tried to stop drinking for a few days, but she got really sick. She was throwing up, she had tremor, and the withdrawal she wasn't able to handle that, and she resumed drinking. She admits loss of control with drinking, craving, history of blackouts. And her home life is that she's married, she has a 6-year-old and an 8-year-old, and she owned her own business doing personal caregiving for elderly patients. And the Monument platform I work for, they require us to do pause, and we're going to talk about what that is. So her score was 3, which is actually really is low, and we'll talk about all that means at the end of the case. So we're going to come back to this. We're going to talk about after this talk, what would you write for her? What does the pause score mean? And because she's got withdrawal, does she need a higher level of chaos? Or we'll kind of go through those questions and how I treated her. So moving on to how does alcohol compare to diabetes? We know diabetes is terrible. We're seeing it every day. When I was a resident, I thought I was going to be doing diabetes practice, and now I'm here doing mental health and substance use. So new stats, and actually in reviewing the cases, the CDC actually just updated their stats on alcohol. Before they were saying 95,000, but they had a new modeling system. So as of June, they're saying 140,000 people die from alcohol per year from alcohol-related causes. So that includes cirrhosis, motor vehicle accidents, accidents from under influence, some cancers that are all precipitated or worsened by alcohol use. In comparison, CDC is saying 100,000 people die on average from diabetes. Now, there's more people with diabetes than technically people with alcohol use disorder, but my next point is going to be that you don't have to have use disorder to have risky alcohol use or have harm from alcohol use. And so about 1 in 10 will have diabetes in the US, and 1 in 20 will have an alcohol use disorder. Again, we'll talk about that. Risky alcohol use can be just as harmful as alcohol use disorder. And reminder that alcohol and tobacco are in our top 3 of preventable deaths. Anybody knows me, I love prevention. So that was a nice stat, I thought. Okay, moving on here. Okay, so my point is that, again, you may not have an alcohol use disorder, but risky alcohol use can definitely have negative consequences. And so I hope people will walk away with this one question screener and will never ask again, do you drink alcohol? And they will use this one question screener for every time you ask about alcohol. But in order to know and use that one question screener, you have to know what is one drink. And so I think as students or residents, we don't always know what is one drink, because patient might tell you 1 drink of wine. My patient, when I actually had her pour water into her wine glass held 16 ounces of water, which is 2 cups, which is equivalent to 3 drinks. So anyways, I might have just given away my next one, but this is a question for you guys. So which of these is equivalent to 14 grams of alcohol? 14 grams of alcohol is equivalent to 1 standard drink. So is that a 5-ounce glass of wine, a 16-ounce beer, a 12-ounce of malt liquor, or 2 ounces of hard distilled liquor? So give a question there. Is it wine? Is it the 16-ounce beer? What's equivalent to 1 standard drink, 14 grams of alcohol? I get everybody.
The answer for A.
A lot of A's? Okay, good. So everybody knows. So wine is 5-ounce glass of wine. Okay, so how many glasses of wine in 1 bottle? Does anybody know that one? I'm going to share the picture on that one too. So 1 bottle is equivalent to 5 glasses of wine. So the people on my Monument platform, a lot of women presented with drinking a bottle of wine a night. So that's 5 glasses. That's technically a binge every night. Okay, so and in visual format, 12-ounce beers, the small cans, patients will often say, oh, it's the big can. well, is that the 16 ounce? There's 20 ounce and there's 24 ounces. So always clarify what size beer are you drinking and how big's your wine glass. And some people will say, oh, well, I have 3 drinks. Okay, what's in your drink? Oh, vodka and alcohol. How many shots is in there? I don't know, I free pour it. Okay, well, if you're free pouring, you have no idea. It's probably double than what they're reporting. So 1 drink of mixed drinks, probably 3 or 4 drinks, right? There's a serious difference there. Okay. And then bottles. Of course, if their patient's drinking bottles, you know they got issues. But just an idea, a fifth is 17 shots. Again, 1 shot is 1.5 ounces. That's 30 or 44, 45 mLs. A liter, again, is 1,000. So it's a little bit bigger than a wine bottle. A wine bottle is 750 mLs. So a liter is 1,000 mLs. That's 22 shots. But people will tell you drinking a fifth or they're drinking a quart. So that's like about 8 shots. So it's a lot. If they're telling you about bottles, it's significant. Okay, so here's the one question single screener for risky alcohol use. When I started my work in New York and I was asking about alcohol, I was like, I really need a quick way to identify people if they're having issues with alcohol. And so I started using the one question screener, and I've never gone back, and I still use it and teach everyone about it. So the NIAAA recommends which question as the best single question screening for risky alcohol use. So this is one question that hopefully you walk away and have memorized by the time you leave this talk. Do you drink alcohol? How many drinks do you have a week? Have you had problematic alcohol use? How many times in the last year have you had more than 5 drinks if you're a man, 4 drinks if you're a woman in one day? And again, I clarify, 12-ounce beer, 5-ounce glass of wine, 1.5-ounce shot. So by the nature of the question setup, you should get this because the details is in the details, right? So we're thinking it's number 4, right? Yes. Okay. Number 4 is the one question screener. So we're going to repeat that. Repeat it to yourself at home while you're eating your sandwich. How many times in the last year have you had more than 5 drinks in one day? 4 if you're a woman. And that's being a 12-ounce beer, 5-ounce glass of wine, 1.5 shots. So just say it one more time in your head. How many times in the last year have you had more than 5 drinks in one day? 12-ounce beer, 5-ounce glass of wine, 1.5-ounce shot. Memorize that, walk away with that. We'll bring it back. Okay, I'm gonna talk more about that. One more time, think about it. What's in your mind? Repetition is the memory, right? How many times in the last year have you had more than 5 drinks in one day? 4 if you're a woman. Okay, I think you got it. Just holding on to that for a quick second. So I really want you to walk away with this. You will always ask alcohol this way. Okay, so somebody says 3-4 times or 2 or 3 times. Okay, if you answer yes, 1 time in the last year you've had a binge, you're actually at high risk for having risky alcohol use. So how good is one question? So they studied this in 2009 Journal of Internal Medicine. They took almost 400 patients. So what they concluded, this one question screener was 80% sensitive and specific for unhealthy alcohol use. It was 90% sensitive, which means it's going to pick up 9 out of 10 patients with alcohol use disorder. But it might over-diagnose, so 65% specific for alcohol use disorder. So you're not going to miss people, but you might overcatch. Okay, so it's not as specific. So you have to kind of clarify. But a lot of people will tell me, they might answer yes to that binge and say, oh, but I've actually had more trouble in the past, but I have been drinking a lot less, where they had alcohol use disorder in the past, they've really cut back, they've no longer been drinking so heavily. But again, binge drinking is high risk. So if one question is positive, that's a positive thing. You want to educate on low risk drinking. So no more than 7 drinks in a week for women, no more than 14 drinks for men in a week. Keeping to 3 to 4 drinks a day for men or 2 to 3 drinks for women is lower risk drinking. That's associated with less harmful outcomes. We're talking about drunk driving, arguments, blackouts, overdoses, right? The stuff that can kill you if you're blacked out, under influence, intoxicated. Okay, and if you answer yes, you kind of say, well, drink more than you intend. Have you had consequences? Do you have tolerance? Do you have withdrawal? You can start asking the questions for alcohol use disorder, so you know, you've got this patient who answers yes, they've had a binge in the last year. So you can have the alcohol use disorder criteria in your mind. It only takes answering yes to 2 of these questions to be considered alcohol use disorder. So people can have mild alcohol use disorder. If they're binging, most of the time they actually have alcohol use disorder, because if you're binging, usually you've lost control, and that's number 1. More than had times that you ended up drinking more or longer than you intended. So you had, when you drink, you always drink more than you intend is what I typically ask. And most people who are binging answer yes to that, because otherwise you wouldn't be having 10 drinks, right? Craving, think of a drink so badly you couldn't think of anything else. I have thoughts of alcohol. Ever had a blackout, memory loss? So blackout and memory loss is down here, is right here, right? So if you drink more than you intend and you've had a blackout, you've got alcohol use disorders. That's mild, but maybe you have more consequences, right? So, but you can put alcohol use disorder at least mild, and then you follow up. Tolerance and dependence is drinking more than you usually do and not getting the same effect. Having tremor, restlessness, shakiness when you stop drinking, that's withdrawal. Giving up activities that were important to you, those are consequences, right? You're spending a lot of time drinking or being sick from drinking, caused job troubles, showed up late to work, had an argument with spouse, missed your kid's event because you were under influence, right? So craving is specific, and we'll talk about that. I would say probably most people have craving unless they really have cut back and made a lot of big changes, but people who are actively drinking, the thoughts of alcohol can be really intense, and that's when naltrexone comes in. Okay, so outpatient treatment overview. Okay, so you use your 1-question screener, which in your mind is, how many times in the last year have you had more than 5 drinks in one day? Or if you're a woman, 12-ounce beer, 5-ounce glass of wine, 1.5-ounce shot. Okay, so you've identified somebody who's at risk. So, and they do have criteria for alcohol use disorder. So screening, identification, put it in the chart. Do they want help? Do they want to make a change? They say, yes, I'm drinking too much. I can't keep having these fender benders. I had a DUI. They want change. So what do you do next? So assess for withdrawal risk, contraindications, and their support system. So here's where pause can come into play. We're going to talk about that in a second. You want to do a maintenance medicine and withdrawal med. We're going to talk about that, and then coordinate close follow-up. So the ASAM 2020 guidelines, these are new. There were no guidelines for alcohol use, alcohol withdrawal prior to this, which is crazy. We had a lot of information, but no actual clinical guideline. They recommend following up with people for 5 days. It could even be by phone. In general, I haven't done this, but that might be a confidence level. So that's what the guidelines recommend, but in practice, I have not done that. If someone's in person, get a urine, get ETG and ETS. We'll talk about what is that, and provide them additional resources. Okay, so first thing, assess for withdrawal risk. Say, hey, yes, I do want to change. Are they actively drinking right now? If they're currently drinking and they're at risk for withdrawal, maybe you want to do the pause. Now, I want you to go to your phone right now. I know everybody's at home. I know people are doing other things, eating lunch and maybe even driving, but hopefully only listening at that point. I want you to go to your MD Calc. I want you to open that. I want you to put in there PAWSS. Then you can star it. Okay, so if you go into your MD Calc, or if you have, the other one is Calculate, either of those. I think MD Calc only has the pause. Yeah, it's the MD Calc only. So pause is listed there. So hopefully you've pulled it up and now you've started. So it can be under your favorites. And if you're on the inpatient setting, this might be helpful because this tool was validated in the inpatient setting. And what it did was identify people who are at risk for complicated withdrawal. Complicated withdrawal is seizure and DTs, where you probably need hospitalization, okay? Now, I wanna say that they require pause for our online company as a legal measure, kind of a CYA. And I have treated people, the woman on my case, who has a low pause score, treated her withdrawal. And I have treated people with higher pause score still in an outpatient setting, even though that was maybe at risk or had close follow-up. So in general, I have never turned anybody away, have always treated people, but this can help guide you if you felt uncomfortable. You know, you can refer to a higher level, you can refer to detox. The reality is, I think most people don't go. It has to be really bad. people get hospitalized for some infection and then they'll address their alcohol. To go just for alcohol, I think people just don't make that commitment typically, and they're looking for some way to kind of get themselves help, but not have to take 2 weeks off work, which is a huge commitment. So anyways, I usually try to meet people where they're at. If they're showing up to my clinic, I'm going to give them my best go, obviously give them warning signs, but that's just my caveat. So anyways, 93% sensitives, 99% specific for complicated withdrawal. So again, this was inpatient setting. Now, if you're using this in the outpatient, you're kind of the person's okay because they're in the outpatient world, right? So the pause might be oversensitive in that setting, and they have a positive blood alcohol. There's other tools available too. Of course, there's a CWA, there's a SAWS, but you can't even find the SAWS. CWA's available, but maybe more challenging. I don't know. So you can use CWA too, of course, but pause is a newer one. So identify withdrawal, identify tremor. And so the ASAM guidelines say that if your tremor is mild or none, you can stay as an outpatient. So mild is maybe your CWA 10 to 18. And, experience provider, close monitoring, treat the withdrawal. Now, the woman in the case who had nausea, vomiting, and continued tremor, and she would go back to drinking, she was probably moderate to severe tremor. I treated her, but she was not complicated. She didn't have DT. She was never admitted. She never had a seizure, right? So the ASAM guidelines say that you should refer those people to where they can maybe have daily on-site monitoring, where they can come or check in, or maybe you do actually make those phone calls for a few days. Guidelines are pretty clear and across the board. If someone has complicated DTs, complicated withdrawal, so DTs and seizure, it's typically severe withdrawal, you need to go inpatient. You need to be there, and you're going to need benzos for sure. Okay, so benzos treat the seizure. All right, so I attended the National Addiction Medicine Conference, American Society of Addiction Medicine in 2020. So this was during pandemic. So this was a virtual talk. This talk really helped me change my practice and helped me feel really comfortable in treating outpatient withdrawal. This lady, Jess Poole, is actually a colleague of mine from medical school. She went to University of Cincinnati with me. So I'm presenting their slides that was presented from ASAM. So they had this algorithm in their talk. Looks really complicated, but they used the pause. And so their main things is, did they have a caregiver available? So the home support is really important. If they're less than 4, you could do gabapentin, carbamazepine. We'll talk about what those were. You could consider benzodiazepine administered by the caregiver. If it was 4 or 5, they were still pretty comfortable, especially if you had the home caregiver. But what they were saying, over 5 of a pause, maybe refer to medical detox. Again, I have treated people with higher levels, but those people probably still needed additional support eventually and needed help. Not necessarily that they had bad outcomes, just that they probably had more serious alcohol use disorder. So their contraindications was pregnancy, age over 65. I think age over 65 is a very soft call. If you look at the age of, if you look at the ASAM 2020 guidelines, they just kind of like took 65 as a mark. I would really say other comorbidities that are significantly uncontrolled congestive heart failure, advanced liver disease, uncontrolled diabetes, so like at risk for infections. And then I would say that the history of seizure or DTs probably is a hard call. Those patients need to go in hospital, okay? Multiple prior episodes, I'm not sure, because sometimes I had a guy who quit drinking, had cut back a lot, he was starting to slip. He had admissions. But I still worked with him. Impaired cognition, right? If you can't follow directions and you can't be outpatient, and unable to take PO, right? If you're vomiting in front of you, then you need to be admitted, right? There's nothing you can do at that point. Summary, this is a busy slide. The way I look at this, is there significant withdrawal that needs treated? Yes. Is it complicated? Seizure DTs. If so, you need a benzo and they need admitted. If it's not complicated, they have tremor, treat the withdrawal, have a close follow-up, and we'll talk about the withdrawal management. Is the reliable caregiver support person? So say they do have significant tremor, but it's not DTs or seizures. Is there someone there, if things aren't going well, that they can take them to the ER? If there's not, maybe we need that higher level of care. Maybe we do make that referral. Maybe we don't stay at home. Okay, so the support giver is really important, and some people have it and some people don't. If there's not someone to have extra eyes on the person, you got to think about, is this safe? Okay, now here's the protocol. Without using benzo, we'll talk about differences between benzos and gabapentin. Now, we have primary care doctors. We are familiar with gabapentin. We write this for neuropathic pain, other pains, a million other things. Gabapentin is used for all kinds of stuff, right? Pros and cons of gabapentin, but I think that we're familiar with it and how it works, sedation effect, et cetera. So in general, you have a loading dose for the first few days. Withdrawal symptoms are very severe in the first 48 hours. So you want to give people lots of medicine and load them up, okay? And you tell them, if you feel overly sedated, cut back, okay? If they felt drowsy or disoriented, take less. The idea is to control the withdrawal. So these are some options. I'm going to show you what I write. This is supported by the guidelines. Anywhere from 1,800 to 2,400 milligrams is supported by the ASAM guidelines for gabapentin loading dose. And ASAM actually talks about loading doses, especially in those first 48 hours, even for really severe withdrawal. And so then you kind of taper down after 7 days. Carbamazepine can be used. I'm not as familiar with carbamazepine, seizure drug. Maybe the mental health guys are. I've been writing carbamazepine more frequently because of my mental health work that I've been doing. But in general, this wasn't a drug that I know the ins and outs of, so I don't write this as much. Now, if you're on the inpatient side, you can write benzos. You have a close follow-up. They do have serious withdrawal. Maybe they really do need that they're having that severe withdrawal, but not seizure. Maybe you do write the benzodiazepine. Now, I have a bad experience with, this is Librium, chlorodiazeoxide, right? So we had a lot of cirrhotic patients in IPS, and if you gave them Librium, they were just conked out. That's a bad drug to use in somebody who's cirrhotic. So don't use Librium in the cirrhotic patients. Diazepam is better tolerated. It's a different pathway through the liver, less sedation. So if I was to write a benzo, I'd be using the diazepam. So 10 to 20 milligrams every 6 hours, 10 to 20 milligrams every 8 hours, and taper down each day. Okay, so you can take a screenshot of that or get this at home. But typically I avoid the Librium because all too often, if they're that severe, then they have liver impairment, and then you get them really sedated, and they stay later, and they have aspiration, no good. So use the less sedating and avoid that liver metabolism issue, and use the diazepam. Okay, so this is what I usually write when I say, okay, you've got withdrawal that's impairing, is keeping you from stopping drinking. So I write 300 milligram tablets. What I put in the box is take 1 to 2 tablets 3 times a day for 2 days, 1 tablet 3 times a day for 2 days, then 1 tablet 2 times a day for 2 days, 1 tab at night. So you can kind of see the tapering. So you can take up to 6 tabs in the first day, and then first few days, and then 3 tabs in the next 2 days, then 2 tabs, then 1 tab. And you write 30 tabs. It's about 24 pills, you give them 30 tabs. Now, pros and cons of using gabapentin. You can still overdose with gabapentin, right? Alcohol with gabapentin can still cause overdose. So even you're not using a benzo, but still can be an issue. Why use gabapentin and not a benzodiazepine? Benzo is the first line. It's best for seizure prevention. Why do something different? Well, the person already has an alcohol use disorder, so prescribing a benzodiazepine that is also known to create another use disorder can be problematic. People might want to continue the benzo. Most people like the benzodiazepine to treat their underlying anxiety. There's the risk of overdose with alcohol and benzo use. I would say the gabapentin, I try to limit the scripts. I usually don't give a refill on the gabapentin because I want to know how much they're using it and what's going on, so I don't do refills. And of course, getting the urine drug screen can better help what the patients are taking. Some patients with alcohol are already taking benzos, but they're not telling you. Okay, so let me go back. I think, okay, did I talk about? Yes, I think that was the main thing. Okay, so moving on to treatment. So we're talking about withdrawal, gabapentin versus benzodiazepines. So moving on to maintenance medicine. You've treated the withdrawal, they've come back to you. There's 3 treatment options that are FDA approved and 2 that are not, but have been studied. naltrexone, disulfiram, and camprosate, and the non-active periods gabapentin. Now, gabapentin has a good, people want to use it for alcohol, but the evidence is actually that it just reduces the number of heavy drinking days. So it's not the best, and that's why I write the limited scripts. So really, you got to get into motivational interviewing, etc. Topiramate has been pretty helpful, and again, it's less controlled. We're going to go through each of these in detail. Good for folks with seizure disorder, the need for mood stability, heavy trauma history. So naltrexone, here's why I like naltrexone, and I think after doing a lot of work, naltrexone is easy. It usually really works, and it can help. The main thing about naltrexone is that it changes how you think about alcohol, the craving, the thought. So it also should reduce your buzz or high. I don't know, in practice and hearing people give me feedback, what I hear what is most effective is they're having less thoughts about drinking. If you're having less thoughts, then you're having less behavior. Some people have called it miraculous, where they can walk by the alcohol in the grocery store and not have to buy it, when before that was just a huge trigger. That's huge. It comes also as a 1-month injection. It's Withdrawal, so that's a brand name, very expensive, $1,000 per injection, but it's out there. You can still drink while taking the medication, so if people aren't ready to quit just yet, but they really do want to reduce, good for moderation goals. The cons, you can't take it with opiates. So chronic pain patients on opiates, people on Suboxone can't take naltrexone. You can still get intoxicated. The side effects are fairly frequent. I would say about 1/3 of people report side effects. So nausea, upset stomach, headache, fatigue. So I tell people take it at night, maybe just stay at the lower tab, or take it every other day. Technically, you're not supposed to use naltrexone in cirrhosis and liver failure. Now, you have tons of cirrhotic patients in your clinic. I was there, I worked there. Knowing what I know, if naltrexone helps somebody stop drinking, people's cirrhosis can actually heal. So in my mind, if they're not having success with a camprosate or topiramate or something like that, I would consider using the naltrexone. Just keep an eye on the liver function. Maybe you repeat the liver functions and you make sure they get the blood work done. But in reality, if people quit drinking, their liver is going to improve. And I think that I don't think naltrexone is harming them. Maybe they just, maybe you stick to 25 milligrams a half tap, right? So I don't think the naltrexone is going to harm them. The risk is maybe the drug accumulates. So if you stay at the lower dose. So I take this with a grain of salt. And I think in a patient who really needs it, I would probably write it even if they have that diagnosis of cirrhosis. Okay, a camprosate. Lots of pills, 3 pills that are huge, 2 tabs, 3 times a day. Who can do that? So I typically don't use a camprosate. I have a few patients that use it. They say that it helps them. I keep writing it. If it's helping them, great. But very few people can keep to this kind of regimen. It is safe in liver disease. It's safe to use with opiate-dependent patients. So I have written it in these cases. It's a lot of pills. You have to keep an eye on kidney function. And of course, you can still get intoxicated with it. Okay. Now, disulfiram, 250 to 500 milligrams per day. Now, this works for people who have not tried, who have side effects to naltrexone. I have moved a few people from naltrexone intolerability over to disulfiram, and it seems to help them get through and kind of change their habits, become a non-drinker. Once you identify as a non-drinker, you've kind of made it, right? So it can be stepwise. However, if you look at the data, does it really work? It says no. The evidence for effectiveness is actually pretty limited. So pros and cons. I think it has its place. It's not my first line. Naltrexone is my first line. So pros, minimal side effects. This is a drug that works in the periphery and not in the brain, so there's less side effects. Works well for motivated patients. They really don't want to drink, but they're having cravings. They really just want to take alcohol off the table. If they take the disulfiram, they know they can't go out to the party. They're just going to make a different plan. They're not going to meet the friends at the bar because they don't want to get sick. And they said that it tables it, okay? So the way it works, knowledge of sickness equals deterrence, right? So the metabolite of alcohol plus disulfiram makes you nauseated and throw up. There's no dose change for cirrhosis. So also an idea, if disulfiram and camprosate don't work, again, think about going back to naltrexone despite the liver impairment. The con, what people tell me is they do have to wait more than 12 to 24 hours if they've taken that dose and then the next day try to drink. Sometimes people still get sick. So that's still a deterrent. But you have to take the medication for it to work. Motivation. What's the #1 change in substance use? Motivation. So if the patient isn't motivated, no change. Okay, gabapentin. So Pros, it could be continuation from withdrawal management. There's evidence for decreased number of heavy drinking days. Okay, that's what we have. The cons, tolerance and dependence. Gabapentin you can become tolerant to. In some states, it's actually a scheduled drug. And I was in Florida and gabapentin was scheduled there. Most patients like their gabapentin. It can be a medicine that has issues. As the opiate epidemic has resurfaced, we are writing more gabapentin to try to avoid opiates. And there has been skyrocketing gabapentin use. So, with a grain of salt, gabapentin still can cause tolerance dependence, keep those scripts short. There is some addiction potential there. Side effects, sedation, brain fog, dry mouth. Those are real and warn patients about those, okay? Especially as we age. Topiramate, using this more frequently, getting more comfortable with this. Anti-seizure med, some studies for off-label use of PTSD and nightmares. So topiramate's been studied in the veteran population. And so folks with really heavy PTSD, they've got nightmares, topiramate you want to think about. Good for comorbid migraine. Cons, it requires slow titration. Metallic taste, brain fog, warfarin, slowness, tingling, weight loss, nausea, sedation. It's a lot of side effects. In the right patient with mood stability, trauma, topiramate could work. I would say that topiramate is not your mood stabilizer. If people have real mania, topiramate is probably not your best idea. It's not FDA approved for mania. So everything with a grain of salt there. Okay, moving on, checking time here. Let's see, I have my clock up. 36 minutes. Okay, so this is a resource list that I give for patients. Alcoholics Anonymous, Smart Recovery. If you don't know about Smart Recovery, this is a great alternative to AA. There's some apps, NOMO, Drinkers Helpers. Monument is the company I work for, but they have groups that are free. And then you can pay for additional subscription to see a counselor and a provider, but the groups are free. So this is nice. Rethinking Drinking. I love this website. If you actually get involved in folks who are drinking alcohol and you want to understand a little bit more, Rethinking Drinking is a great website for basic stuff. ETG, ETS. These are metabolites of alcohol. I use these as just to keep the conversation honest. Never penalize people for continuing to have a positive alcohol result. Now, the level of detection, the literature says 3 to 5 days. And I was actually looking on Reddit and reading about this, and people can, man, if you hydrate and do 2 liters, apparently you can get by. So you can have a pretty bad binge, and if you're really hydrated, you may not show up positive. So I think at best it's 48 hours if you're doing heavy binge, if the patient's really hydrated. Pay attention to the hydration status, the creatinine level in that urine. Metabolite of alcohol technically can be false positive from food sources, but if the ETG is positive and the ETS, you know it's alcohol, right? So if both of those are positive, it's alcohol. So going back to my woman who's 40 who had significant nausea, vomiting, and tremor, and so she resumed her drinking as a result. Does she have criteria for alcohol use disorder? Yes, loss of control, 1, craving, 2, history of blackouts, 3, she has having arguments with her spouse, 4, worsening depression is 5, she had a fender bender under unsafe issues, so that's 6, so she has severe alcohol use disorder, okay, plus probably, I think she answered positive to every question, she has tolerance and withdrawal, 8. Her POS score is 3, so now we know that the POS score of 3, she's technically not at risk for complicated withdrawal. So what do we do? What do you want to do for her? Do you think she should stay at home? What do we do? So take a few minutes to just think about that. So what I did is I did write her naltrexone and gabapentin the same way I did, and I followed up with her in a week. And I gave her explicit instructions that if her withdrawal was not being treated, if she was still throwing up, then she had to go to the ER to get a benzodiazepine prescription through this online platform. I can't actually even write controlled substances. So if she took even the maximum. So how did she do? She did well. She made it through. She followed up. She had actually multiple follow-ups with me. It was rough, she told me, but she was still having some tremor, but she didn't throw up. So she's been better. She's still seeing a therapist. She's still engaged in treatment, but she's had some slips back. So her goal was to stop the daytime drinking. We talked about 0 alcohol goal. She did stop completely for a while. Her husband was doing a breathalyzer test on her. And so there was motivation there to not drink. And so some conflict with those boundaries with the partner. But she's recently started going back to drinking because she was having withdrawal. So I probably, and she wanted to resume the gabapentin, so I probably will write her the gabapentin if that's what she needs to kind of keep in control. Then I will do that. And again, close follow-up, she had kind of fallen off. So these were the goals. Hopefully, you know, walk away with a 1-question screener. You're a little more familiar with alcohol use disorder diagnosis. You know what the pause is with a grain of salt. You can use that definitely on the inpatient side, grain of salt on the outpatient side using pause, because this was studied in patients. And maybe you're more comfortable using gabapentin instead of benzodiazepine. These were my preferences. Questions? Okay.
If anybody has questions, please feel free to unmute or put in the chat box there for us.
So for the gabapentin, that needs to be renally dosed. And have you had a lot of issues with that, or how about these other drugs for renal dosing?
Again, so I think the camprosate is the renal dosing. You know, on this platform, when they're not getting labs, most people are healthier. So yeah, I typically, is a good point. I don't often think about that. But that is a good point for folks who have got kidney issues when you've got more severe patients. I would say that the outpatient side, the folks that I'm seeing have not had CKD, but you guys definitely have lots of CKD. So gabapentin, I would just use lower doses. Let's see. Renal dosing, address the dose frequency. Yeah, I would probably do half of what the script is if they had, you know, GFR of 30, you know, their creatinine is 1.5, 1.2. Okay, so what's been your success rate for sustained abstinence? Haha, great question. Thanks, Brian Hepburn. Okay, so 1, sustained abstinence. What's the goal? My goal is to meet the patient's goal. If the patient's goal is to moderate, and they're moderating and they're drinking less and they're not blacking out, I've been successful. So sustained abstinence, we've got to let go of that idea. Treat the people where they are. Most people have to try to moderate and fail moderation before they go to zero alcohol use. So you meet them where they're at. I don't have data on how many people are zero alcohol. No, I'm not keeping those stats, but I would just say, let go of your idea, let go of your provider idea that the patient's doing great if they're not drinking at all. They may be having significant improvement if you just step down their alcohol use. For this woman, for example, she's drinking 10 plus, right? There is good evidence that stepping down moderation. So if she can get to low risk drinking, she's going to have significant improvements. She's not going to have the fender bender. Maybe she's going to have less arguments. But I would say she's a high risk patient that some drinking may tend to always slide into worsening alcohol. So we're going to have that continued conversation, of course. A good question. What else you got out there for me? Have you guys dealt with that? I know people had alcohol withdrawal on IPS, and Librium was knocked people out who had cirrhosis. So have you guys been writing naltrexone for? Now you guys this is new interns, right? July 1st. So lots of new faces. So deer in the headlights out there. I hear you. Naltrexone, you can initiate that before they leave the hospital. Follow up, see if it might help them. You don't have much to lose.
I have a question about ETS and ETG. So some workplaces, including the Texas Medical Board, when they monitor people, is that what they're using, those tests?
Yeah, I think so. Yeah, they're newer. So it's better than using just like urine alcohol level or like blood alcohol level. So ETG, ETS, they say 3 to 5 days, but I think people can get by. So it's good to monitor. And it's you got to have some sort of data. So yeah, so it's going to pick up. You have to have stopped drinking for longer to be clear of the ETG and ETS. So, and I'm sure you can order it. It's definitely available commercially. Like if you go into Sunrise, ETG, ETS are going to be in there. I know you guys changed to Epic?
Yes. Yes, we did.
Changed to Epic. So it's in there. I'm sure the hospital has access to it, but it's probably not included in your regular urine drug panel. So if you're talking about alcohol, do your urine drug screen, but add in the ETG, ETS.
So your practice is all telemedicine now, I think. Is that what you told us before?
My practice?
Yeah.
The current practice that I'm working in?
So, well, I guess my point is a lot of us are not doing only doing a limited amount of telemedicine. Can you talk a little bit about your transition and, you know, what you think it's good for this, obviously. What about other uses of telemedicine? Any comments on that?
Sorry, I'm not sure. The question was how did I get from family medicine to doing more substance use-based care?
Yeah, and then the efficacy of doing that by telemedicine.
Oh, and telemedicine. Okay, right. So that transition was my job in New York. That was a federally qualified health center. They were offering, if I did this specialty practice, I could get 30 minutes with patients, and so I jumped at that. And the woman trained us and did a really great job. So I learned opiate use disorder extensively, you know, had a panel of Suboxone patients, 80 patients that I followed. And so from there, I got certified in addiction. In that certification, you know, always came back to like alcohol. Alcohol is so preventable. So many people, there are still more people dying of alcohol use disorder and alcohol-related complications than opiate use disorder, right? So there's a lot of overdose death going on, but overdose deaths alcohol still contributes. Alcohol is like in the sidelines. People don't want to talk about it, whatever, it's legal. People die of alcohol every day and it doesn't get the highlight, right? So certification to alcohol, certification to addiction medicine, getting more experience, getting involved with ASAM. Once I was addiction certified, I was looking for jobs so I can continue doing addiction work. And so the practice I'm in currently, the brick and mortar practice, was mental health. And they jumped at the chance, oh, we definitely need someone who's addiction certified. There's a lot of methamphetamine in El Paso where I'm at. They needed Suboxone patients. They wanted somebody with some expertise. And so I got into the mental health job. And so now I'm seeing schizophrenic patients and doing long-acting injections and basically acting as a psychiatrist and doing an outpatient residency in psychiatry, but feeling pretty confident in it overall with, you know, I have two psychiatrists on board. So I ask them questions and I'm not alone. So I've got good backup if I have any issues. So that's been my transition is looking for 30-minute appointments, more time with patients, specialty, doing more mental health. The online platform, I had done that as just to kind of was bored in pandemic. We had a 1-year interim. So I picked up the Monument company and it's been really rewarding because people who get on that platform want to make a change and show up. And so I've got some people who are chronically, you know, seeing them every month. I've got 15 visits, you know, logged with them over 2 years. So I don't think I would do that full time. Just because telemedicine stuff, they can't guarantee patients. They pay me based on visit rather than per hour. So if people don't show up, I don't always get paid. So I don't do that full time. It's just a few patients a week. Okay, so Lynn Vivian sent me a message privately saying, patient in the ED with funding issues, intermittent housing, social work provided resources for outpatient detox. Would naltrexone have been the best option in retrospect? Yeah, he definitely could have used naltrexone, you know, write it for them, give them a little bit of background, can make you feel tired or nauseous, take it at nighttime, but it could definitely help with their cravings. you know, I would assess for withdrawal risk. What's their active drinking? They might have need gabapentin, but it's reasonable to start naltrexone even if they cut back on their alcohol use. Could be a big help for that person who's in an unstable living situation, and alcohol probably negatively affecting spending money on alcohol versus trying to get things in line. Okay, other questions? I know we're almost out of time here.
I'm not seeing any other questions in the chat box here. So I just want to take a moment to thank you again, Dr. Houston, and thank you to everybody who joined us. I did put the link in there so we can provide you some feedback on your presentation. So if everybody could help us out with that. But thank you again so much.
Now I'm just going to leave everyone with one last challenge. Think about what's the one question screener. In the last year, have you had more than 5 drinks in one day? 4 drinks if you're a woman, 5-ounce glass of wine, 12-ounce beer, 1.5-ounce shot. The answer yes to that. Ask about the alcohol use disorder questions, and you'll start catching lots of people who have issues and maybe really do want to talk about it, but no one ever asked.
Thank you so much. Everybody have a good day. Thank you.
Bye-bye now.
Thanks, Laura. Really appreciate it.
You're welcome, Dr. Nato. Pleasure. If you want me to do opiate use disorder, I've got to work on putting that talk together. So combination of.
Well, we're glad you came home. Thanks for coming home.
How are all the residents doing? New interns, huh?
They are doing great. I'm on the wards right now. We're having a great time.
I remember